Welcome to EO Talks, Eastern Oregon's very own talk show, only here on EO Alive.
Hey, Eastern Oregon, thank you for joining us today. We're continuing our series with the MAP program that's put on by CHD, which is the Medication Assisted Treatment Program. And today I'm joined with Dale McQueeney, who is the psychiatric nurse practitioner from CHD, and you help organize and run that program. And Dale, thank you so much for being here with me today.
Happy to be here.
Yeah. So Dale, let's start a little bit. For people that don't know you, talk to us just a little bit about you and where you came from and how did you get involved in this, and being a a psychiatric nurse practitioner. That's a little, people might not even know that there is such a thing. So kind of what led you to that career?
Well, I actually wanted to become a psychiatric nurse practitioner to work with people in addictions. I've been a psych NP for 6 years now. And for the bulk of my career, I worked in a rehab facility. And I loved it. It was fantastic. And when I got the opportunity to work with CHD and their MAT program, I jumped at the chance. So it's just always been a passion of mine to work with people in addiction. And I've really seen people change their lives through a combination of therapy and medications such as buprenorphine or Suboxone, and a program of recovery. It's been amazing. It's been really fulfilling.
Well, and, we have talked, I think this is the fourth or fifth segment that we've done, and you and I have been trying to get together for a while. It sounds like your schedule is crazy, and part of that is because you're kind of at the core of this program. You're monitoring the medication that is assisting folks that are going through the program. And so I can understand there's quite a bit of demand on your time. So talk a little bit. Let's start with, what are some of the things that someone might see in themselves or a close loved one that might indicate that, hey, I'm concerned that I or my friend or my loved one might have a problem here. What are some of the things that you notice or that someone might notice?
Sure. And that's one of the first things I do when I meet with a client in an evaluation for the MAT program is I go over the diagnostic criteria for an opioid use disorder. So one of the first things that we look at is, do you have a persistent desire, or have you made unsuccessful efforts to cut down or control your use of an opioid like heroin or an opiate pill? Or opiate pills, I should say. Do you spend a lot of time trying to obtain the substance, to use the substance, or recover from using the substance, whatever opioid that might be? Do you have a craving or a desire to use the substance? And I usually have clients rate that craving on a scale of 1 to 10, with 10 being the worst. And then we can compare that as time goes on and after you've been prescribed the Suboxone or the buprenorphine. Has your use resulted in a failure of major role obligations in your life, like work or school or home life? Have you continued to use in spite of social or interpersonal problems that were caused or made worse by your use? Have you given up or reduced important activities in your life? Have you continued to use in spite of having a physical or psychological problem that was caused or made worse by your use? Do you have tolerance, which is defined as needing increased amounts to achieve intoxication, or having less effect from the same amount of the substance? Or do you have withdrawal symptoms? And these can include things like shaking, sweating more than normal, feeling hot or cold more than normal, runny nose, watery eyes, goosebumps, diarrhea, vomiting, muscle aches. Those are all things that we look for. Those are the diagnostic criteria for an opioid use disorder.
And those are all things that someone could experience themselves, and their loved ones or their family might not even notice. So in other words, maybe they have the cravings, maybe they're delaying social activities to be involved in that, or whatever the case might be. So they're carving out this place in their life, but they're still fully functioning people. They're showing up to work on time and so on and so forth.
Sure. I mean, you could certainly hide cravings or a desire to use. Right. You could be trying to cut down or control your use, and nobody knows that. Right. I mean, some things are more obvious than others.
Right. And so, so immediately I'm thinking, oh man, I have this coffee problem, a lot of that fits in there. I have a craving for it, or chocolate or food. I mean, you can kind of throw a lot of different things in that bucket, but,
sure.
But I guess the question is it affecting your relationships? Is it affecting, some of those other things that you mentioned? And those are kind of what are you giving up in order to maintain this addiction?
There's one there, excuse me, but there's one that I forgot. Have you used in situations where it's hazardous to do so or dangerous to do so? That's one that I left out. That's something like, have you driven, things like that? Mm-hmm.
So, and this, this sounds like it would be great for a checklist. I mean, this would be a great handout, or a great, something is like, so people could just look at that and go, and maybe that's the video that we need to make is like, yeah, if you're checking a lot of these boxes, then you might not even know, but you've got a problem, and maybe you need to look into it. So what is, so then what is the tipping factor for a lot of people? What's the thing that, like, maybe the thing that you don't want them to get through? Maybe it's an overdose. But what's the tipping factor that you see in people's lives to where they're finally like, okay, I can't ignore this any longer?
I think it's different for different people. I really do. I think, a lot of times it's the withdrawal symptoms is what I see, is that people can't tolerate the withdrawal symptoms anymore, or they can't tolerate the cravings anymore. Those are the biggest things that I see, is the withdrawal symptoms and the cravings. But I think it's different for everyone, different for different people. But those are commonly what I see, or that's just, well, often also too, is that it's just interfering with their life so much and they can't function. And I also will screen for other addictive behaviors, and also for pain. A lot of times people started using opioids to manage pain. That's not uncommon. And I also screen for dual diagnoses or co-occurring disorders such as depression, anxiety, bipolar disorder, things like that, because we look at the whole person, not just the opioid use disorder.
Because some of those other issues might hinder. So even if they finally get to the point of like, okay, I need to do something about this addiction that I have, if there are some of those other things that are spinning out there, it might hinder their progress, them getting better.
And hinder recovery. Absolutely. Yes.
Yeah. So
we have to look at it all.
Yeah. So then we've talked with a little bit about the intake process with one of the nurses or a couple of the nurses. We've talked with different parts of it, but when they finally get to you, when they finally have gotten through, they've done all the paperwork, or they've done all the stuff they're going to do to enter the program. They've made the call, which is probably, the biggest obstacle of all, because they have to admit to someone that like, hey, I think this might be a problem for me. So when they finally land in front of you, tell me what they experience and tell me what you do with them.
So, like I said, the first thing I do is I ask them about their substance use history. I ask them, when did you start using heroin, for example, or opiate pills, and at what age, and how much do you use, and when did you last use? And then I go over those diagnostic criteria that I just went over with you. And I confirm that opioid use disorder. That's important because you need to have an opioid use disorder in order to be prescribed buprenorphine or Suboxone. And then I do screen for those other addictive behaviors, the pain, the dual diagnoses, or the co-occurring disorders. And then I perform a review of systems. I ask about what you're currently experiencing physically to look for other possible medical problems, either co-occurring or associated with drug use, such as skin infections or abscesses if you've been injecting, or to ask about hepatitis C or HIV. And if you haven't been tested, I'll test for those, because that's important to rule out, because some of these, if you're injecting, for example, that puts you at risk for things like that. So I'll do a review of systems. And then I do some things about screening for the depression, the anxiety, the bipolar disorder, other mental health diagnoses. And then I provide a lot of education about Suboxone and buprenorphine and how it works and the possible side effects. And I can talk about that now if you'd like.
Yeah, no, yeah, go ahead and talk to us, because as I've asked that question a couple of different times, they've said, well, Dale's going to have to break that down for us. So,
Sure.
Yeah, so tell us how Suboxone works.
Sure.
Why is it effective? Yeah, kind of give us the breakdown of what happens there.
I'd be happy to. So there are other medical treatments for opioid addiction. I should talk about that first.
Okay.
Including methadone and naltrexone. But what we prescribe in our program is buprenorphine or Suboxone. Suboxone is a combination of buprenorphine and naloxone, which is Narcan. Is commonly referred to as Narcan. But I should say, first of all, that all medications should be used together with psychosocial treatments, such as counseling, mutual help groups, such as a 12-step program. And that's why our program includes meeting with a clinician and a peer or case manager, and we encourage strongly attendance at groups. But I heard you ask previously, why are we treating one addiction to a drug with another drug? And I equate it to treatment for any other disease, such as diabetes. And one could say that a person is dependent on insulin for their diabetes. They need that medication, but we don't question that.
Right.
And it's very much the same thing with an opioid use disorder.
Good.
So I wanted to bring that up, because I heard that in a previous.
Yeah, no, thank you, because that is a question. That is a question, and part of what I want to do is, hit the questions that people are asking, but maybe don't ask straight out. Yeah,
it's a good question. Yeah. So buprenorphine or Suboxone is an FDA-approved medication for treatment of opioid use disorder, addiction, that's both a stimulator or agonist and a partial blocker of the opioid receptor. So it's a partial agonist. And Suboxone, again, is a combination of buprenorphine and naloxone or Narcan. And the naloxone is an opioid antagonist. It blocks the effects of opioids. And it's not absorbed orally. The naloxone isn't. It's there to discourage sniffing or injecting the medication. The opioid agonist effect of the buprenorphine reduces withdrawal symptoms and cravings, while the blocking effect at higher doses prevents or lessens the effect or high of using another opioid drug. And what's protective about buprenorphine, or the partial agonist nature of it, is that in the presence of an agonist, like an opioid pill or heroin, is that the partial agonist is competitive and knocks the agonist, the heroin or the opiate pill, off of the receptor. And that's actually what prevents overdose. And if the receptors are already occupied by the buprenorphine, the heroin or the full agonist can't bind there. You can also think of it this way. The buprenorphine is a stronger magnet to the opioid receptor than the heroin or the other opioid or the full agonist. And remember, it's not the naloxone in the Suboxone that does that. That's just there to discourage misusing the medication. Did that make sense?
I think that kind of does. Yes,
Okay.
I wish we had some little diagrams.
I know.
You know, yeah, but essentially, you're talking. There's two different components. One is that it so that if there is other opioids in the system, it makes them ineffective because
it knocks them off.
Right. Okay. That's one aspect. So then it's difficult for people to overdose even with Suboxone, because you can't take too much of it, because I mean it's just a very unlikely situation. Yeah.
It also has a ceiling effect.
Right.
Right. So you can't really get as high on Suboxone because it's a partial agonist.
Okay.
Methadone is a full agonist, and you can kind of have more of a high on it than Suboxone or the buprenorphine part of it, because it's only a partial agonist. So there's a ceiling to it.
Okay.
It's competitive with a full agonist, so it knocks off a full agonist like heroin or an opiate pill or even methadone.
Okay.
So yeah. And what's dangerous, what can be tricky about it, and why you need to do an induction carefully, is someone needs to have 24 to 48 hours off of an opioid, like a full agonist, like heroin or an opiate pill, before you do an induction. Because if you take it too close to when you have a full agonist in your system, you can go into precipitated withdrawal, because the buprenorphine is going to knock all those full agonists out of your system and make you very sick. And it can be dangerous because you can have excessive vomiting and diarrhea, and it can cause an electrolyte imbalance.
Okay. Okay. So,
are you following?
I do.
Okay.
Yeah.
Okay.
So, and I guess one of the things that I found appealing about this program is that it's holistic. It's, there is the counseling side. We talked, one of the sessions was about helping people find housing. I mean, so there's just because, people often that find themselves in this situation are also, maybe they're having complications with the law, and that affects whether they have housing or not, or it affects their relationships. And so that counseling, and so I love that you guys have prepared to handle all of the things, the complications that can come along that might keep someone from recovering. And that was the term that you used earlier that I was searching for.
Yeah. And you've met our team. I mean, they're dynamic. Yeah. You've met Brooke and Lisa and Nikki and Lindsay and Jamie. Yeah. I mean, Yeah.
And they're passionate about it, and they're very coming much at it, and it's this team that's coming, they're looking at this issue from many different perspectives. And that's kind of what I seek when I'm building a team for my business or whatever is I want people with various perspectives, various opinions, different experiences. So then what we come up with is complete. It's holistic. It's not just one person's idea. And clearly this is way more critical of a process than what I'm going through as a business owner, but it still applies. So talk a little bit about what supports. So then once you figure out the dosage that is required to help this individual begin to recover, what's the process? What's next?
So I continue with the education that this is important. I think this is an important point I'd like to make, is that opioids, heroin, opiate pills, all opioids can cause lasting changes in the brain. So it's recommended that people stay on Suboxone or buprenorphine for as long as the person finds it helpful in meeting their goals in recovery. And people on Suboxone or buprenorphine treatment have a lower risk for relapse and overdose. It's literally saves lives. So I know that there's some people who think that if you're on a medication like this, that you're not truly in recovery. And I don't hold that opinion at all. And I think it can be for as long as, again, as it's helping you meet your goals in recovery, however long that is.
Because at the end of the day, it's better than the alternative.
Absolutely, but
yeah,
I think
yeah.
more positively than that.
Right.
I think it's just another tool in your recovery toolbox.
Yeah. But I mean, if it's affecting your life, your relationships, your job, then I mean, you're right. It's the tool that you have. And, I get that. And, and I think that, I mean, and that's a very important point and I think that part of that is then, we've talked about a huge amount about this with COVID is that, man, everybody's on their own journey. They're trying to sort this out their own, through their own lives. And we got to give people a little bit of grace and room to be able to find their own way,
Yes.
So good. Thank you.
So what I do is I explain the induction process, and that it generally has but basically it can either be in the office or it can be a home induction. And clients are given a small amount at first, and then they generally wait an hour and take another small amount, wait an hour, take another small amount, and it goes by their symptoms and how they're feeling. They'll generally feel quite a bit better after they take the first dose. If they're still not feeling well, they'll take another dose. If they're still not feeling much better, they'll take another dose up to a certain amount that I set. And then when they reach the dose that makes them feel pretty normal, they let Lindsay, our medical assistant, know what dose they reached, and I write a prescription for a week's dose, week's worth. And then they generally follow up. They follow up with me in a week. Not generally, they do. They follow up with me in a week. And I obtain informed consent at the end of the evaluation. And they agree to certain things like to keep their medication safe and to not, divert their medication and, general things like that. And they, of course, are educated on the process. So they agree that they've been educated and that they don't have any additional questions. And I review our tier guidelines. Basically, we have a structure to our program, and we have tiers that clients go through. And in the first tier, which is where all our clients start, they meet with the prescriber, often me, weekly, and get a week-long prescription. And they meet with their clinician weekly as well, if possible. And they're encouraged to attend groups, and they get peer support from Brooke or Lisa, or case management support from Brooke or Lisa. And they get weekly random urine drug screens. And we just wrap around them as much as possible in that first tier. And then it becomes less frequent every 2 weeks if they're successful in adhering to the tier guidelines, and then less frequent from there every month, and so on. We like it to be, as you said, a holistic process, and provide the tools that they need to support their recovery.
Now, there sounds, and you'll correct me if I'm wrong. So, and again, could be a totally ignorant question, and I'm sorry if it is, but
no ignorant question.
So this addiction, is there an element of opioids or being addicted to opioids that gives you a high, or is it just you're avoiding the withdrawals? And then if there is a high, then how do they have to get used to not having the high in Suboxone? I mean, I don't know. Are those issues, because it sounds like you're giving them enough Suboxone to suppress their withdrawals, and to maintain them safely. But do they have to get, does it have a different feeling for them that they have to get used to being on Suboxone versus being on some kind of opioid?
Well, the Suboxone addresses both the cravings and the withdrawal symptoms.
Okay.
Yes, but it's not going to give them the high that the full agonist or heroin or opiate pill gave them. But that probably went away anyway. They've been probably chasing that high because the changes in the brain that happen over time from using drugs, anyway, they'll never really achieve that again because the brain changes. It's like it makes changes, permanent changes to the brain over time, and you're always chasing that high.
Interesting. So then, okay, I follow that. So then let's go back to, it sounds like the program has some accountability built in. So they're only getting a week dosage at a time.
Initially.
Yeah, and I think that part of that is they're having random drug tests during that time to make sure that they're not taking any other medications.
Well,
talk about that a little bit.
We're checking to make sure they're not taking other medications, but importantly, we're also checking to make sure they're taking the buprenorphine or the Suboxone.
Ah, good. Okay. All right. Well, man, I think that, I was telling someone else that we're having, as you know, probably better than anyone. I mean, there's laced medication that's laced with fentanyl that is in our community right now, and it has made this whole topic even more relevant or more volatile, probably, I think. Yes. Is maybe than what it normally would be. And I've been fortunate enough to not really know anyone that I knew that was suffering with this, and then come to find out, I discovered that one of my close friends that I worked with probably 10 years ago, recently died from overdosing on the laced fentanyl tablets.
Wow.
Yeah,
it's very scary.
It is, but those are the things that addicts are at risk of.
Absolutely.
If they're not getting their medication from any other place than a pharmacy, they're risking it not being pure. They're risking that they could overdose on something like that.
That's right.
Yeah.
That's right. And we would love to help. Yeah. I would love to help. We all would.
Right.
And we hope that people will reach out to us, to our program, so that we can provide that help.
Well, Dale, thank you so much for being here today.
Yeah, I'd love to give our Hope line out.
Yes, please do so.
Our Hope line is 541-562-HOPE.
All right. Yeah, and that phone, somebody's going to answer that phone, and that's kind of the beginning of the process for people to be able to get help. And I'm sure I've said this before, that even if you have a loved one who you're concerned that they need help, they can call on their behalf. And and I'm sure that you guys will give them advice and talk to them about, how to move towards solving some of these problems that are affecting them.
Absolutely.
All right. Well, thank you, Dale, so much for coming on today. I really appreciate it. And thank you, Eastern Oregon, again for tuning in, and we'll see you next time right here.